Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today, our topic of discussion is about ocular immunology. And in ocular immunology, we will talk about intermediate uveitis. Intermediate uveitis is a very challenging disease, and it can, if not properly managed, it can lead to certain complications. Today, we have invited Dr. Abdul Sattar Nasir Farag, and he is currently uveitis and medical retina consultant in Royal Wharton Hospital. Dr. Abdul Sattar has done his fellowship in uveitis from Bristol Eye Hospital and Birmingham and Midland Eye Centers. Apart from this, he has also done training in medical retina and uveitis from University Hospital, Leicester. So without further delay, I will request him to please present his talk.
Thanks, Dr. Azim, for your kind invitation. It's my pleasure to present uveitis topic today, which is one, as you mentioned, of the main challenging uveitis presentation in our daily practice. And I believe, to be honest, that intermediate uveitis, if you know the concept and the way of thinking in and how to deal with intermediate uveitis, in my perspective, it may be one of the easiest uveitis case. But all what we need to do is a standard approach, and just we need, as I selected this title from adapting this title from the famous book by David Allen, which is Getting Things Done. So you need to classify any case of intermediate uveitis. Is it actionable or non-actionable? Do we need to take an action and treat, or we need to observe? Because not every single intermediate uveitis require treatment. So first of all, this is 58 years old male referred with bilateral recurrent intermediate uveitis. He was confused. There was some abnormalities in his OCT finding, as we can see here. And this is one of the landmark publication about OCT characteristic in intraocular lymphoma. As we can see here, there may be pre-retinal pigment epithelial nodule, as in figure A, or subretinal infiltrate as a confluent band, or mixed intraretinal and subretinal infiltrate, irregular RBE. All these can be suggestive feature for intraocular lymphoma. This patient has an urgent MRI, and as we can see, it shows lymphoma. So this presentation can be serious. So intermediate uveitis, although it's one of the topics that, if we understand, can manage the cases without hesitation, but at the same time, we should not forget that it may be a presentation of a life-threatening condition. So take care, it can be very serious. So I'll not go through the standard history taking in uveitis, because if we are talking about this, we will take ages, and I'm trying to be focused more on the practical aspect. So just quickly, what is the signs of the intermediate uveitis? These signs, when we see, we can label it as intermediate uveitis. Vitritis, as we can see here on the right eye, there is no vitritis, but left eye, there is vitreous hazel vitritis. This is different grade, so this is like grade 2 on the left side, vitritis +2, and here is like +3 vitritis. Snowballs, which is really, really highly characteristic for intermediate uveitis. As we can see here, snowballs is very characteristic, very unique, very obvious. We can see it in intermediate uveitis cases. And the third sign is snow banking. As we can see in this arrow, it's snow banking, which is an inflammatory exudate. And to be honest, snow banking for me, this is a video I took from one of my patients in the clinic. So it's reverse it. So this is by the superfield lens using digital slit lamp. you can see this is the typical appearance of the snow banking, but definitely this not superior snow banking, it's inferior snow banking, but because as you know, the superfield lens shows a reversed image. So, and the last sign is maybe associated peripheral retinal vasculitis, like in this condition. So, which is highlighted by the red free. And here is the critical things. Don't forget in any intermediate uveitis, detailed iris examination for nodules or heterochromia or iris transillumination. Re-examine if you found that posterior subcapsular cataract, because one of the common misdiagnoses, like, okay, this phoeoxyterochromic uveitis, they have vitritis sign or vitreous opacities, and then misdiagnosed as an intermediate uveitis, and the patient just treated, over-treated, and he doesn't require, there is no need to treatment. So usually young adult with posterior subcapsular, with vitreous opacities, with few cells in ACE, is it intermediate uveitis? I doubt it. We have to rethink and re-examine for heterochromia, check the angle, gonioscopy for any other signs, look for other signs for first heterochromia. It may be, but I think we have to consider this in our. And this is what I used to tell all my trainees whenever they attend my uveitis clinic. Look for any retinal lesion or vascular sheathing, and look all the way down for snowballs and snow banking and retinoschisis. So I tell them, and I do it in my clinic intentionally whenever they are with me, to show them how it is important. Look down, all the way down, as much as you can down and right, as much as you can down and left. And here you will find the snowball and the snow banking that missed by previous examiner commonly. Because if you don't look in extreme periphery, few snowballs can be easily missed, and the snow banking is the same. So like this retinoschisis investigation, and this is what I recommend as a standard protocol for intermediate uveitis. There is no universal agreement on investigation for intermediate uveitis, but this is what I believe is most useful. First is metabolic panel. So we need to know about how the overall condition of the patient and different system, full blood count, urea and electrolyte, liver function test. This is the first section. Then we do infective screening, which is basically syphilis serology. And as you can see, this is the only infective screening in intermediate uveitis that I recommend on initial presentation. But quantiferon test and Lyme serum antibody, as you can see, I put it as a question or like exclamation mark, because intentionally we don't do quantiferon test for patient with intermediate uveitis unless there is a specific condition and specific situation. I'll talk about it later on. And Lyme serology is useless. Don't do it. I cited here, as you can see down the slide, a famous publication about diagnostic sensitivity of and specificity of Lyme serology. And the conclusion of this publication is it's only indicated if there is typical systemic manifestation of Lyme disease or typical clinical presentation of insect bite and endemic area or specific areas. So I don't do it. I can't remember. I did it in last 4 years, maybe once. Okay, so it's not recommended. Going back to quantiferon test, so we do quantiferon test in intermediate uveitis if there is a definite exposure to tuberculosis, if it's a chronic bilateral intermediate uveitis that is not responding to treatment. Okay? Chest X-ray to exclude TB and to exclude sarcoidosis. Inflammatory causes and markers, so angiotensin converting enzyme, ESR and C-reactive protein. And I'd like to highlight here, ESR and C-reactive protein by its own is not like diagnostic for anything, but it's an indirect indication or an indirect clue for what's going on. If it's sky high, then you should suspect either very aggressive autoimmune disease or infection. MRI is indicated in certain situations. First, if you suspect intraocular lymphoma, definitely you should do MRI. We don't do MRI as a routine in intermediate uveitis, although maybe in some countries they do it as a standard. I don't agree with that. I believe that MRI should be done only if there is suspicious of intraocular lymphoma or there is any neurological symptoms which you found during history taking, or if there is any or before, or if there is any family history of MS. And the last thing before starting anti-TNF, if the patient require anti-TNF or biologics, then you have to request MRI. Ocular imaging, this is what I recommend. I am very generous in ocular imaging because I believe in uveitis, it's a standard practice now, and you are decompensating patient care if you don't use all the ocular imaging that you have. Ultra-wide fundus photo, as we can see here, OCT macula to detect OCT intraretinal or subretinal fluid, or as I mentioned, maybe a clue for intraocular lymphoma, and OCT disc. And OCT disc basically to detect any retinal nerve fiber layer thickness and disc swelling. But as I showed here, I use the OCT disc swelling, OCT disc as an indirect indicator for improvement of or response to treatment. Like this patient, we can see here increased retinal nerve fiber layer thickness with time, with treatment, we can see it's going down. And as we can see here, marked improvement from up to down here over different visit. And fluorescein angiography and ICG to detect peripheral vasculitis or any signs of vasculitis, whatever. Indocyanine green angiography, there is no strong evidence that indocyanine green angiography as a standard thing, but from my own experience, I do it, and it was useful many times to diagnose sarcoidosis cases. B-scan, if there is no view of the posterior segment or very bad view, or you suspect mass or whatever. And here is the main message and the main thing, which is actionable intermediate uveitis. So you deal with intermediate uveitis case. There is intermediate uveitis case. So we'll do the standard thing. We'll do baseline history, examination, and investigation. Okay, we did all that, and then we should ask ourselves, is there associated systemic disease or infection? So yes, there is a possibility like neurological things or infectious disease, syphilis, rheumatological disease. Then we refer to specialist medical team in addition to ocular management. Okay, so there is two parallel pathways that we will work on that in if there is associated systemic disease or infection. Medical team to deal with this systemic thing and our ocular management. Then in the other possibility is no systemic infection or associated systemic disease. Then we focus mainly on ocular management. And here is the most important question that we should ask ourselves. I saw intermediate uveitis. Then a trainee come to me asking me, Mr. Farag, I have seen this patient with intermediate uveitis. The first thing that I ask him, what do you think? Is it actionable or non-actionable? Because this is the main thing. So if it's non-actionable intermediate uveitis, then all what we need to do, just observe. We don't need to treat. If it's actionable intermediate uveitis, then you need to follow the management of actionable intermediate uveitis. The questions that come in our mind now, what do you mean by actionable intermediate uveitis? So we excluded already an infection. So if you exclude the infection and no infection need to be treated, then we are talking about actionable non-infective intermediate uveitis, because infective screening is the main thing. So any patient with intermediate uveitis with decreased vision, cystoid macular edema, retinal vasculitis, or disc swelling, any feature of these four, then we should or we must treat. Okay, the reason for that, because it has consequences. The worst thing is under treatment for uveitis patient. Decreased vision, it doesn't mean six vision that it's a good vision. quality of vision. I have seen patients 6'6", and I have treated them because the quality of vision is terrible, is terrible. So the vision may be 6'6" or 6'9", but the quality of vision is very bad and usually will be associated with other features. And then actionable intermediate uveitis, is it unilateral or bilateral? So if it's unilateral, then we have subtenon or orbital floor. I don't prefer, to be honest, orbital floor. I included it, but myself, I don't prefer it. It's a blind procedure. You go by needle. Risky. Why? We have subtenon steroid injection. You go, you see what you are doing, less complication. So why to consider orbital floor? So I don't recommend it. I don't do it, but I have to include it as a part of guidance or as a part of the available modality. And if it's bilateral, then I offer patient systemic steroid. Someone may ask me, can we do bilateral subtenon injection? Yes, I have one of my patient or two of my patient. They didn't like to have systemic steroid, so I did right eye first and then left eye or whatever, left eye then right eye. I don't do bilateral injection at the same time. It's difficult for the patient. Even some patient with systemic, some patient with unilateral intermediate uveitis, they may refuse injections. They don't like injections. Then I give them systemic steroid. So all these two lines are like indicated. It depends on your discussion with your patient. Um, if the subtenon not working properly or patient has a flare up again, then I start to think about slow release intravitreal implant. As we know, we have two famous one, the most Ozurdex, which is they claim 6 months, but I believe from my experience, usually it's 3 or 4 months. It's very variable. I have one patient with intermediate uveitis that I gave Ozurdex and she didn't get it again. So now for 3 years, nothing, everything's fine. But other patient, and usually we tell the patient it's 3 to 4 months. The other thing is Iluvin, and Iluvin is a longer action. They claim 36 months, but usually I tell my patient, usually it works for 24 months. So this may be a second step after trying subtenon and recurrence or flare up, it depends. Non-corticosteroid immunomodulatory, when we consider immunomodulation or second line immunosuppression, regional failure, if there is failure to respond to periocular or systemic steroid, systemic failure, active uveitis while taking 0.5 milligram per day or more, steroid intolerance or need for steroid sparing effect because of long term. Other surgical management include pars plana vitrectomy, like for diagnostic biopsies. A case that I mentioned initially was intraocular lymphoma, significant vitreous opacities despite adequate immunosuppression, and severe visual loss from tractional retinal detachment, vitreous hemorrhage, or epiretinal membrane, retinal ischemia, and the new vascularization. You need to use retinal laser photocoagulation. Cryotherapy to peripheral retina, I included it. It's in literature, but to be honest, I didn't do it before. I haven't good patient that require it. So there is evidence that we can use in case of pars planitis due to risk of induced inflammation. Thank you.
Well, thank you, Dr. Abdul Star. It was a really very informative presentation, and you have explained in detail about the concept of actionable and non-actionable intermediate uveitis. And it was very interesting and worth attending your lecture. One thing is, just want to ask you, Doctor, about the use of topical steroids. What do you think? Do you use it? Is it efficacious? What is your
No,
point about it?
so basically, this is what I'm trying to stress in my clinic whenever there is like either trainee or that in, intermediate uveitis cannot be treated by topical steroid. So topical steroid, we give topical steroid to treat the associated anterior uveitis, but intermediate uveitis, the prednisolone acetate 1% or dexamethasone, eye drops, whatever, the penetration power, they can't reach to the vitreous, okay, for treating, they are not strong to treat intermediate uveitis. This is the reason that I selected the main title is actionable, because if it's very mild and intermediate uveitis, you don't need to treat, you don't need to give topical steroid. We should not forget that topical steroid has its own side effect, cataract progression, glaucoma or steroid response, increased pressure. All these are risk. So without evidence or justification, I don't recommend. So you have to evaluate, take history, examine, investigate, decide if do investigation and then decide, is it actionable? Then if it's actionable, we have two options, either regional treatment, which is steroid injection, whatever the types, if, after exclusion of infection, definitely, and systemic, which is systemic steroid. That's it. Yeah, but we should not use it. We use it as a part of treatment of associated anterior uveitis.
Well, Dr. Abdul Sattar, what is your opinion about the use of indocyanine green angiography? One thing. And second is about the investigation, systemic and these blood works and systemic imaging. When do you repeat during your treatment?
Okay, perfect. Thank you. So basically, for indocyanine green angiography, I recommend, if you have an access for it, I recommend to be done as a part of the initial assessment. So any patient with intermediate uveitis, I arrange an ultra-wide fluorescein and indocyanine green angiography. And then if there is finding of indocyanine green angiography, then I repeat it to monitor the response. But if there is no finding, then I don't do it again unless there is a new sign or something that I need indocyanine green. But there is no strong evidence in literature. I have to be honest with that. But my personal experience, it was very helpful for me in many cases, especially that start as an intermediate uveitis and then later on develop to panuveitis. When you have a baseline with peripheral signs, then it can change your labeling and diagnosis from intermediate to be panuveitis, because once there is involvement of the choroid, it's not intermediate uveitis, it's panuveitis. So this is the first thing. Second thing, when I consider assessment or requesting systemic investigation. So basically, if there is a new manifestation or new symptoms or signs with my patient, if there is a change of pattern, okay, like if the patient like developed neurological symptoms, one of the common questions that I tell my trainee to ask when you see the patient for a follow-up, ask them, is there is any new health issues that you have since our last visit? So that's it. If there is new health issue like related to like for instance neurological symptoms and I didn't request MRI, then I request MRI. Or there is a respiratory problem and then I repeat like I may consider if there is ocular features of sarcoid, I may request high resolution CT. So that's it. Yeah.
Well, Dr. Abdul Sattar, what is your threshold for moving from the steroids to the biologics? One point. And secondly, how do you use fluorescein angiography and OCT to manage and this subclinical macular edema?
So basically, regarding the first thing, which is related to the threshold. So first line, we use systemic steroid on the first presentation. And then according to the UK guidelines, we can't get funding to intermediate uveitis for biologic straight away. So if there is recurrence and they are indicated for immunomodulation, then I use second line immunosuppression like mycophenolate mofetil or methotrexate. Then if failure of mycophenolate or mofetil or methotrexate, whatever that I selected, and failure to control the treatment, control the disease, then we can escalate to biologic. And the common biologic that we use in these cases is adalimumab. Basically, it's 40 milligrams subcutaneous injection. The standard dose is every 2 weeks. Yeah. regarding monitoring for subclinical. So we are like lucky in the UK system and National Health Service NHS in the UK that we have access for our patients. They are not paying anything, so we can deliver without hesitation the best care. So patients, they are not paying for investigation. So why to decompensate your care? So myself, every patient will come to my clinic, will have an OCT macula, will have ultrawide fundus photo, and the baseline, if there is intermediate uveitis on first presentation, baseline ultrawide fluorescein and ICG. If the ultrawide fluorescein and ICG shows finding, then I start treatment and I repeat the ultrawide fluorescein after 3 months after finishing the treatment to see the response to treatment. And then if everything's fine, no flare up, I repeat the fluorescein in 1 year. But OCT macula, I do it every visit. Yeah, because it's an objective measure, and I believe it becomes now part of clinical assessment. Yeah, maybe this practice may not be suitable for other countries where the patient they have to pay. To be honest, if the patient need to pay, I may be different. But again, I don't think we have to find a way to fund these things. Even if the patient has to pay, they have to be covered by insurance or whatever, because it's an objective assessment. It's an objective assessment. That's it.
Well, Dr. Abdul Sattar, it was a pleasure attending your lecture, and you explained the different aspects of intermediate uveitis, a very challenging aspect of ocular immunology, and you explained the concept which I earlier said, actionable, and it will be, I believe, it will be very beneficial for our respected audience in their clinical practice. I want to thank you on the behalf of my audience also for giving us time for this beautiful lecture. Thank you.
Thank you. Yeah, it's my pleasure. Yeah, you are always welcome. Okay.